Okay, so good morning, everybody. For those on the line, I'm actually not in the room today, unfortunately. I'm have to do this remotely. So, welcome to those in person and those on the line. It's before we begin, I would like to respectfully acknowledge that the University of Alberta is located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. I am absolutely delighted to introduce today's speaker, who is one of the newer members of our department. So Dr. Heather Armstrong is Associate Professor in the Division of Gastroenterology in the Department of Medicine here. She's received numerous national and international awards for her work and over $25 million in research funding and published over 20 manuscripts in her first 3 years on staff. This funding supports her team's work to uncover how changes in the gut microbiota can impact the way the body responds to different environmental and dietary factors, and the positive and negative impacts that result from infancy to adulthood in disease settings such as inflammatory bowel disease, multiple sclerosis, liver disease, and cancer. She's a committee member with several national associations, including SIDSCAN and the Canadian Association of Gastroenterology, international groups including WINGS and GYA, and is a co-lead of the African IBD research endeavor. She's going to be talking today about changes in the microbiome from birth through adult life impacts how the gut responds to dietary fibers. So over to you, Heather. Thanks.
Thanks so much, Norman. All right. So I did give a talk fairly recently when I was being onboarded for this position. And so I kind of wanted to change things up and just give everybody a sense of the involvement of the gut microbiome and some different areas that we could be looking into or means of collaboration within the department while highlighting some of our work as well. My conflicts include I'm also a scientific advisor with Dayhoff Technologies, but that doesn't really pertain to this specific talk. So not everyone's really going to understand what the gut microbiome is, and I think it's kind of important that we start with highlighting what we're actually talking about. So the microbiome isn't just the microbes themselves, it also actually includes their entire environment, which is, the pH, the metabolites, what the host cells are pumping out. So the entire environment of that microbe community. So when we talk about the microbiome, we're actually really talking about the entire gut. Whereas the microbiota, the microbe community within that environment, so those are all the different microbes, their functionalities, and the microorganisms are obviously the individual microbes. But when we talk about the microbiome and talk about development, I think it's a pretty common misconception that most of your microbiota is inherited from your mother during the birthing process. And sure, there's an aspect of that that's true. You do certainly see differences between cesarean births and vaginal births. And so you are directly receiving some microbes from your mother during that process. But there are a lot of other environmental exposures that are going to help with that microbiota development in early life. And it's really that first 3 to 4 years of life that are really important for the microbiome to develop. But you think about, maybe not as much these days, but a lot more in the past. You would have had all those exposures to family, to friends early on in life. Baby would have been passed around to so many different individuals. You get in contact with the skin microbiome, different environmental microbes from soil and animals and things like that. And so the entire environment around you is what's helping shape that gut microbiome. And then there's other factors that play a role as well that we'll kind of get a bit further into as we go. And so, like I mentioned, the gut microbiome by about 3 to 4 years of life is relatively stable. By about age 4, you've actually got the gut microbiome that you will sustainably have with you for the rest of your life. And so those early years are really essential. There are certainly factors that in your environment that you can change to help change your microbiome throughout life. But really, these first few years are paramount to establishing that gut microbiome. And I've tried to highlight here that, even during the pregnancy process, mum and dad's health and types of medications and diet that mum's taking can certainly have a substantial impact on that microbiome, along with delivery and then early life feeding, be it breast milk versus infant formulas. And I'll kind of get more into that as we go, because that is a project that we have going on. But there are all these different factors that kind of help develop, along with different genetic and host factors too. So it's actually quite complex when we talk about the development of the microbiome and its role in helping then to also promote and develop the early life immune system that's also going to stick with us for life. So it really starts to show, I think, how important that development of microbiome is in those early years to then also ensuring the health of the host. So changes in lifestyle can alter the microbiome and vice versa. We know that throughout life, beyond just those early years, environmental factors like stress, physical activity, nutrition, different pharmaceutical products, where you live and the types of microbes you're exposed to in different areas of the world, and even within different regions, where do you live? So, I mean, I'm a great example. Where I grew up in New Zealand, we actually live very close to a coal plant facility. And that's not a good thing for your microbiome. There's different pollutants and things that you can be exposed to. So there's all kinds of different aspects of your environment that can impact this microbiome development, but you can also utilize these. So, moving maybe one way of changing your geography, but certainly some of these other factors like stress, physical activity, and nutrition are quite readily altered. And so there are means of changing your gut microbiome. But what the studies have shown is as soon as you stop, it's not like you can take a diet for 2 weeks and you're set, you've changed your microbiome for life. You actually have to stick with those changes, or else they simply revert to what your baseline microbiome is supposed to be, what you developed at the age of 4-ish. And so there's a lot of increased understanding of what this means. And when we talk about the impacts of stress and sleep, and now we're talking about the gut-brain axis, which is becoming more and more common to discuss, we're also talking about how the microbes are involved in that process. But what I want to really start to highlight, especially in the Department of Medicine, is that it's not just about these individual organs. And I think if you go back to our basic physiology, I think we can all understand that the microbes are involved in turning primary bile acids from the liver into secondary bile acids, and then communicating those into the gut and into the bloodstream, which impacts other organ systems. The microbes are involved in producing different nutrients and other features, metabolites, that are going to impact almost every organ system in the body. And so when you have these features like stress or sleep deficiency, these factors have been shown to impact the composition of the microbiome and the microbial metabolites, and in turn, those can be involved in the promotion of aspects of inflammation, mental health, gut health, liver health, you name it. And so I'll start trying to kind of tie all of this in together for what our team's been working on. But diet is one of those factors that we're really quite interested in. And the reason is diet is one of the more readily modifiable factors in life. Simple changes are a lot easier to maintain with your nutrition than trying to get someone to make more time to go for a run every morning. So it's easier than physical activity. And then it's easier than telling someone to be less stressed out. I don't think that's a simple change. And so nutrition is one factor that we really focus on. It's also been shown to be the lifestyle modification that can have the greatest impact on improving the diversity of the microbiome and the functions of the microbiome. But what's really important to understand is that, there are some foods that we consume and they directly impact us. We're capable of digesting those foods and producing byproducts ourselves. And there are other food factors, particularly these indigestible carbohydrates like fibers and starches, that we don't actually do anything with as a human being. We require the microbes in our gut to ferment them or break them down for us. And so you can start to see with certain aspects of your nutrition how important the gut microbiome is in this interaction that we have with different nutritional factors like fibers. And so, there are these aspects of microbial-derived components that then have this interaction with host health and vice versa. So this figure really highlights, this is out of Karen and Leo's work, this figure really highlights how this intake of particularly dietary fibers and starches interacts with gut microbiota. This fermentation process occurs, then you get byproducts like short-chain fatty acids. There are many other byproducts that are produced out of this interaction. But these are the byproducts that are actually considered to be beneficial to the host. So when we say a high fiber diet is healthy, what we mean is a high fiber diet must interact with your gut microbiome to produce these byproducts, these metabolites, and that is what engages with the host cells. Or so we thought until some of our more recent research, which I'll highlight a little bit later. And so, recognizing that these guys are key and foundational, again, you're really starting to understand why the gut microbiome is so important. But fermentation isn't just to produce byproducts like short-chain fatty acids. I think it's something that a lot of people focus on is kind of this role of bacteria and fungi in this fermentation process. Yes, it produces short-chain fatty acids, but dietary fibers are actually really interesting. They come bound to different ions. Those are released during the fermentation process. They're antimicrobial. They help to restore and balance the microbiome community. And that's not just in the gut, and I'll highlight that a little later. Fibers also bind heavy metals and other byproducts and transport them out of the body. So these infermentable dietary fibers like cellulose and lignin can be really important for removing heavy metals from the host. And dietary fibers obviously act as an energy source for host cells through this byproduct production as well, causing these kind of immune regulating and gut. I don't like to call it just gut brain anymore. It's gut body roles. It's all these metabolites that circulate out to the rest of the organ systems in the body. And so I've highlighted this before, just how complex this is when we talk about dietary fibers. And the field is shifting for sure. We're starting to see better and better studies coming out. We're not just talking about, oh, high fiber diet is beneficial for you, but it's a mouse study that looked at cellulose and non-fermentable fibers and not much else. We're really starting to see that people understand the complexity of these different types of dietary fibers and how they all come from different foods. They engage with different microbes. It's different enzymes that break them down, and they produce different types of metabolites through that process. And so not every type of dietary fiber is the same, and you really need to start to appreciate how each of these fibers has different roles when it comes to engaging with microbes and their role in the host physiology as well. And so what we've highlighted here is just the fact that, every study we see increased short-chain fatty acid, increased short-chain fatty acid, increased short-chain fatty acid, all these health effects, even from members of our team here in the Department of Medicine, these studies really just highlight that it's not necessarily consuming fibers that's beneficial, it's the successful fermentation of fibers in the gut that's promoting these beneficial activities. And if you look at studies that have failed or flopped in lower journals, typically what you're seeing is they gave their patients or their animals a high fiber diet, but they didn't see an increase in short chain fatty acids afterwards, and they're sitting there scratching their heads going, well, why did we not see an effect? And so what that highlights is it's not just consuming the fibers that's important, but that interaction with the gut microbiome, that breakdown, that fermentation, that's really essential to see the health benefits. And so we know from various studies across the board that when you change the gut microbiome, which is very common in a lot of diseases, inflammatory bowel disease is one that we study, but there are so many conditions where we're starting to see this alteration of the gut microbiome community, even in perfectly healthy individuals. You also start to lose this fermentation process, which means you're losing these byproducts, these very beneficial byproducts. And so there's many studies that are starting to show that there are these changes in the gut microbiome in different disease settings that decreases the production of short-chain fatty acids, suggesting that fermentation is decreased as well. And the question becomes, what does this actually mean for the host health? And also, what does this mean then if we have individuals with this unhealthy gut microbiome, like IBD patients, and then we continue to promote that they consume dietary fibers even though their microbiome can't do anything with them? And so that's what we've tried to understand is these studies have asked patients, how do you feel about this? And they'll constantly say to dietitians and their gastroenterologists and their care team, when I feel like I'm headed for a flare, I think that these high fiber foods are actually my trigger foods. And so I will intentionally place myself on a low residue or low carbohydrate diet. That's not good because we know that carbohydrates are essential for the gut health and gut microbiome health. And so, it's our role to try to understand how do we do this in a safe way? How do we work with our dietitians to try to understand which of these high fiber foods are actually triggering them and which high fiber foods are actually safe and are going to help them kind of maintain and enter back into remission more smoothly. What's quite interesting is you actually start to see this in other disease settings. So completely unrelated, this is multiple sclerosis. this really shouldn't have much to do with the gut, and yet you're seeing similar studies come out where a high fiber diet compared to a low fiber diet causes worsening outcomes for persons with MS. And so, this is where our work has started to shift, is what is the role of the gut and the gut microbiome in some of these other disease settings? Even though we're not seeing inflammation of the gut in these conditions, are we seeing immune activation and some kind of communication from the gut to other organ systems? It's one of the reasons why we obviously recognize the gut as a second brain. And so our work has really started to uncover that, there are types of prebiotic fibers. These are supposed to be beneficial. These are supposed to be broken down by microbes, promoting microbe health and host health. They're supposed to be beneficial, and they certainly are in some cases, even some patients. But they can cause damage if you don't have the right setting. And so our team has shown, I've shown our previous studies, like the gastro paper from a few years ago, that these beta-fructan fibers, inulin and phos, that are considered one of the best prebiotics. If you go on the internet and look up prebiotic supplement, inulin is probably what you'll find first. They can promote gut damage if they're not broken down by an IBD patient. If you follow patients over a 1-year term, those patients who consume significantly increased amounts, so they start taking a prebiotic supplement of inulin, they'll actually more likely promote themselves into a flare over that 1-year period. Whereas those who decrease their consumption of inulin or increase it only subtly, which is probably slight changes in their whole food diet rather than taking a supplement, are more likely to remain in remission over that 1-year period. And that doesn't happen with other types of dietary fibers like pectins, arabinoxylanes, beta-glucans, these other fiber types. And so we're trying to understand as a team why, how are certain fibers engaging with the gut over others, how are they engaging with microbes, and what is putting these patients at risk of progressing to a disease flare simply from nutritional triggers. And so what's quite interesting is we've got a number of different cohorts. We've shown this in rheumatoid arthritis, where it's really the beta-fructans only, again, very similar to IBD. We've shown this in multiple sclerosis, again, the beta-fructans. We actually think the beta-glucans are primarily found in grains. And so sometimes when you see changes in beta-glucan consumption, that can just be patients placing themselves on a gluten-free diet, thanks to Dr. Google. So we're not really sure if that's a true feature or not. But what was really interesting is our fatty liver disease cohort. It's hardly any fiber. It's shocking. No kinds of fiber. It doesn't matter what kind it is. You can see there's a decrease. The blue is healthy control. The red is the fatty liver disease patients. So these are MASH and FLD patients. And you can see across the board, they just do not consume dietary fiber compared to their healthy control colleagues. So interesting. We're not really sure what that means yet, but this is a part of one of the projects that we're bringing with us to U of A. So liver colleagues, get ready. And so, I've noted the metabolites. I've noted the fact that these microbes are responsible for vitamin production as well. Vitamin K and B in particular are a responsibility of your gut microbes community. And these metabolites, yes, we talk about their impact on the gut, and that's what we're seeing at the bottom here, all these delightful anti-inflammatory and gut barrier promoting interactions that these microbes and their metabolites have with the gut. But these different metabolites are also taken up within the gut into the bloodstream, short-chain fatty acids, tryptophan metabolites, neurotransmitters, you name it, they all carry through the bloodstream and out to other organ systems. And so, it screams what happens in other disease settings, like I've started to highlight. And so we know that there are these alterations in the gut microbiome community that happen thanks to other studies that have been done in a variety of different settings. And the ones that we primarily focus on as a team are IBD and different GI conditions, multiple sclerosis, different liver conditions like MASH and FLD, a variety of cancers, and now we've kind of stepped into general stress in the healthy population. So these are kind of the focuses of our group, and I'll start to show you kind of this gut-brain axis link and what we're starting to understand about the gut-liver-brain trifecta. So we've got a variety of studies on the way, and this is obviously a bit more complex for those who aren't too immunology heavy, but essentially what we're starting to understand is if you've got this successful fermentation, you get these metabolites, you get this benefit in the gut, and it creates this resounding benefit that then your host cells kind of promote all of these anti-inflammatory cytokines. Those are taken up into the bloodstream, hurrah. Unfortunately, if that process doesn't occur, you've got this setting where select types of fibers like the beta-fructans, inulin, and phos can then engage with the epithelial barrier, break it down, allow for this leaky gut to occur. They can promote inflammatory processes through TLR2 containing cell types and activation of the NLRP3 inflammasome. And we've really started to hash out what all of this means, the role of the liver and liver bile acids in this equation, eosinophil infiltration, different cell types involved, and then what this means for the carry through into the blood and the central nervous system. And so we're trying to really understand, what does this pathway look like, and what does the host have to look like in the beginning for this to occur? So what we've started to see is, in an IBD setting, the gut is already in this immune primed state, maybe not active inflammation, but immune primed. And so this interaction is more likely to occur. If you take a totally healthy individual, they're less likely for this pro-inflammatory effect to happen because they're not immune primed in the gut. In an MS setting, when we've done this, what we're seeing is you're not seeing inflammation in the gut, you're just seeing mild gut activation, immune activation in the gastrointestinal system, but you are seeing an increase in inflammation in the central nervous system because the central nervous system is primed for that inflammation to occur. And so it starts to suggest, if you've got an individual where a certain organ system is already primed and ready for this inflammation to occur, that's probably where it's going to happen, but it's likely starting with a very mild immune activation in the gut and that cross communication between organ systems. So that's what we're trying to understand. But in doing so, the other question is really, what about the other types of dietary fibers? We've shown that these beta-fructan molecules can be inflammatory, and some more than others. It depends on the food source that they're coming from. So these dark orange guys here are your beta-fructan molecules. Psyllium and arabinoxylan can also be pro-inflammatory, but it depends on the food source, it depends on the host cells, it depends on what's going on. And then you've got other molecules like different pectins and GOS that can be anti-inflammatory and significantly anti-inflammatory in some settings. And this is even if they're not broken down. So they can be healthy even if your microbes aren't. And so that kind of becomes the question of, is this the type of dietary fiber that we should be feeding to patients if they are having difficulty with some of these other high fiber foods, but we still want to keep promoting them to consume certain fibers to maintain that gut health, that microbiome health? And so our team started to really show, it matters which food it's coming from. It even matters what country it was grown in, what soil it was grown in. So it's complicated, and it all kind of comes down to the chemistry, the polyphenols that play a role, and other molecules that are attached to these fibers too. So it's very complicated, and our dietitians have been doing wonderfully in sticking with us through all of this because it's not easy. But we are trying to identify, how do we find the healthiest, most beneficial foods for patients? And so we start to kind of question, this is all well and good. These are whole foods, but where does life start? Where does microbiome development start? Well, in infancy, and they're not eating whole foods yet. They're supposed to be consuming breast milk. So in breast milk, mum actually naturally produces her own dietary fibers without having to eat an apple. Mum produces these human milk oligosaccharides, these HMOs. And so what's really interesting is these are kind of life's early prebiotics. This is what's helping promote the development of the microbiome. This is what's having that massive increase, that surge in bifidobacteria in early life. But what we've done as an industry is for mums who can't breastfeed, we've taken infant formulas and pumped a whole bunch of beta-fructan molecules like phos into the infant formula as a replacement strategy. And you can see here that, if you think about chemistry, HMOs are not the same as phos, they're not the same as GOS, they're not the same as other types of dietary fibers, and so we've replaced it with something that an infant gut wouldn't normally see until they've started onto a whole food diet and they're consuming things like banana, onion, garlic. That's where you would naturally find beta-fructan molecules. And so, you are starting a child off with a very early exposure to whole food is essentially what you're doing, which is why, one reason why, there are a lot of reasons why, infant formula doesn't have the same impact as breast milk. Megan Azard's coming on October 20th, and I'm sure she'll talk a lot more about this work from the child study. And so what we've shown in our very new study that just got funded by Whitcreek to continue at the U of A is that if you take gut tissue from infants and you expose it to FOS, or you expose it to HMO molecules that we acquired from the child group, you can see that a child who's on antibiotics, and this is really interesting because this doesn't actually have anything to do with microbes, these are just biopsy tissues. So you're taking FOS that's unfermented and you're exposing the gut to it. And you've got children who are either on antibiotics or not. And even in those infants where, microbes are out of the question, this is just the FOS molecule and the gut, the host cells. We've shown that the FOS molecule can be pro-inflammatory, but primarily only in children on antibiotics. So there's something about the changes in the microbiome, the introduction of the antibiotic molecule that's actually completely changing the immunology of the gut and allowing it to be more hypersensitive to these food molecules. And it's not hypersensitive to HMOs no matter what's happening. So breast milk is safe. There's kind of the takeaway from this. Whereas some of these infant formulas, there's actually select situations where you could be promoting gut inflammation if you're promoting certain infant formulas. Now, there are more expensive infant formulas from Abbott and other companies now available that have synthetic HMO molecules, and that's what you're seeing on the right-hand side there. That's 3FL and 2FL. That's what you'd naturally find in these Abbott and other kind of HMO-containing infant formulas, and they don't produce an inflammatory signal, at least not one that we've seen yet. So, it's trying to understand in what settings are these different types of fibres all the way back to birth actually safe, and in what settings could we be promoting inflammation at a very early age, and what does this actually mean for the infant health in the long run? So if we're promoting infant inflammation in the gut in an infant at the age of 6 months, what does that actually mean long term for them? Are we inducing perhaps risk of IBD or IBS or something else? And so now we flip to the complete other end of this story. If you've got an IBD patient who's had IBD their whole life and you've been promoting them to eat a high fiber diet and they keep telling you no, 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 and you keep saying yes, 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 we've actually shown that in this particular setting, you can be promoting different markers that are reflective of development of colon cancer. And so again, this is very individual specific. This is someone who has kind of that TLR2 responsiveness. This is someone whose gut microbiome community has been altered. This is someone who's really struggling. But there are certain types of prebiotic fibers that you need to be quite wary of when you're promoting this lifelong in a patient who already has active gut inflammation. So we're not sure how much of a risk this is really promoting at this time because we haven't switched out of our kind of culture techniques yet. We've run one animal study. We have to repeat that a couple more times to really understand what's going on. But we have started to show that, and this is from Leo's clinical trial of the inulin cohort. So these patients were remission ulcerative colitis patients who took an inulin supplement over a 6-month period. And those who failed, but were taking the beta-fructan supplement, started to show these signals, these factors that suggest that you're promoting pro-colon cancer pathways. So it's about really trying to recognize who can safely use these types of prebiotics and where we need to be a little bit more careful. And so like I've highlighted, there are actually lots of different disease settings where this microbiome is altered and probably nutrition too. And we've certainly kind of started to spread our wings into a few of them. But the gut microbiome and the gut truly are connected to almost every organ system. It's really incredible, and there is a reason why they call it the second brain at this point. The gut microbiome community has these direct impacts and indirect impacts on pretty much every organ system at this point. There's actually a study that was even released yesterday or 2 days ago now that Dina sent through yesterday to our groups, suggesting that even a simple stool test is standing up to endoscopy in diagnosing colon cancer through AI tools. And I don't think they're there yet. I went back and kind of skimmed the paper while trying to finish my slides the other night, but I don't think they're 100% there yet, but it's surprising, right? It's pretty shocking that these very simple microbiome tools may be able to replace kind of more invasive tools over the coming years for these type of diagnostics, which is incredible. But it really also highlights the importance of the gut microbiome in development of things like colon cancer. And so, there's so many really interesting studies. The GEM study and Ken Crotore's team has shown that changes in this microbiome community precede development of IBD. So we've been working with them to try to understand what does that mean for nutrition before disease development versus once someone actually has the disease. And so far, what we've been finding is it seems like it's a complete flip. So before you develop the disease, consuming all of these different diverse types of dietary fibers actually seems to be highly protective. But then as soon as that switch is flipped and the diagnosis is made, whether you've actually diagnosed them yet or not, but the disease is there, all of a sudden the interaction changes. The immune cells are primed, they're ready to have this interaction. And so it can actually turn into an inflammatory response instead of a beneficial response. So when does that trigger flip is another one of the questions that Ken and I have been trying to work on together with some of the members from the United States as well. And I just wanted to really highlight, I know Troy, I'm not actually sure if Troy's presented this yet, but I'm sure he's talked to some people about this, but Troy and his PhD student Paul have been uncovering similar microbiome signatures, even present in fibrotic CD. So, there are very specific types of microbes that I think that we're slowly starting to identify for their role in inflammatory bowel disease, and all the way through from development to worsening disease outcomes to surgical outcomes and even post-surgical relapse, which is really fascinating. And it's not just about, are they present in the gut, but where are they localized to? So Troy and his team have been showing that it's about this microbial penetrance and certain microbes actually penetrating deep into the gut tissue that can play a role in this post-surgical relapse as well. But I don't want to leave other microbes out of this. So when we talk about the microbiome, there's a really common neglect of viruses and often fungi as well. And we're really starting to understand this role of the gut virome, and Andy and his team have done some work on this as well. But what certain studies have shown collecting samples from children, they were looking at asthma and chronic inflammatory diseases, is that there are many, many viral species, but most of them, about 90% identified so far, are bacteriophages. And so these are viruses that infect bacteria and will directly impact and shape the bacteria within the microbiome community. And so again, you'll have these good viruses that process is very important. They help shape a very healthy microbiome community. And then you're going to have other viral species that are completely going to derail that community. And so, it's just yet another group of microbes that are really interesting in this entire equation, and like Andy's team's showing, even in IBD. And so, I really wanted to highlight just how far this goes. We've got some collaborative studies that we're doing in pancreatic cancer and looking at the microbiota and identifying, again, a signature. So there's a signature of 17 microbes, primarily bacteria, that are distinguished in pancreatic cancer. And again, could AI technology be used to help in this type of diagnosis as well, using the microbiome as a diagnostic tool? And what does this mean again then for lifestyle factors, nutrition? How do we avoid the development of these types of signatures? How do we avoid increasing these 17 particular microbes to reduce risk? So within this signature, there's microbes like Fusobacteria nucleatum, which is also actually associated with colon cancer. So there's kind of this overlap between different cancer types as well. And then fungi, like I mentioned, so there's different types of fungi. Some of them you'll hear of because they're involved in kind of brewing and baking, but they also live in your gut, and they are also a part of kind of this healthy interaction. They're also involved in the fermentation process. I think bacteria get too much of a pro bono for being the end-all be-all short-chain fatty acid production, but fungi are also actually extremely important, and I think we understand that from fermentation and brewing and baking, that these fungi play a very key role in nutrient metabolism, as well as actually in the absorption process in the gut too. And so these fungi have been associated with all kinds of conditions, GI, hepatology, and far beyond. And so I kind of wanted to highlight too just how far-reaching the gut microbiome community can be. So even if you consider what was previously thought, quite a desolate environment for microbes to grow in. The vaginal microbiota is primarily made up of lactobacilli species and a small number of fungi. That's kind of what the healthy community looks like. But it's interesting because the gut microbiota actually has a direct role in maintaining that happy and healthy community as well. So even when you're talking about different infections, and I mean, bringing this back to your other patients, bringing this back to IBD settings when you're dealing with different viral infections or fungal infections that you may see in patients, a lot of this is actually coming back to the health of the gut and the health of the gut microbiota community and the role that it's playing in kind of destabilizing some of these other organ system microbiomes. But the gut microbiota is really interesting because it helps metabolize and maintain the balance of estrogen hormones in women. And so obviously this plays a role in glycogen production and nutrient availability for different yeast species as well. And so plays a role in different yeast infections and things like that. So it's just incredible how much the gut microbiome community plays a role in kind of promoting these different communities, these different yeast and viral species. And the same said in different infection models. This was a really neat study that came out during the pandemic that showed that, you know, the severity of your COVID-19 infection could actually be coming from the gut microbiota community and different infections within the body, the secondary production of different endotoxins from bacterial infections and the role that it plays in this endotoxemia and cytokine storm and that very severe form of COVID-19 some individuals are getting. So again, it comes back to the gut and the gut health and the gut microbiome. And the last one that I really want to highlight, because this is something that we've been quite interested in, is completely healthy individuals in your performance as an athlete, your stress levels, your overall well-being, even that actually comes back to a gut microbiota balance, the ability to produce these short-chain fatty acids, which are actually directly involved in oxidation in the muscles and production of glucose then in the muscles, which is kind of a similar process to these other organ systems that I've mentioned. But so it's just incredible how widespread and wide-reaching this very simple gut microbes plus dietary fibers, production of short-chain fatty acids and other metabolites. It's all starting in the gut, and yet it has these really widespread impacts both in health and disease settings. And so we've tried to simplify what that equation looks like. This idea of, you know, you'll consume different dietary fibers, which ones, is like one of the bigger questions that we have. They'll interact with your microbes, produce these metabolites, and this fermentation process is the most important part. So this fermentation process, realistically, it's not just about gut health and IBD. That's where this study started, but we've really started to show that this fermentation process, successful fermentation, is about whole health, and a lack of fermentation can really derail the entire system and impact almost every organ in your body. But it really depends on what you are predisposed to as an individual when you're talking about what kinds of impacts that's going to have. And so how do we use this knowledge that we're starting to uncover from our work and that of others to improve the gut microbiome community? And obviously there's kind of this probiotic-prebiotic battle that's going on in the industry, as well as FMT kind of having a sidelined role at this point. But probiotics, I think they're becoming much more complicated because of what we've learned from FMT studies and trying to understand which microbes, which metabolites are important. And so how do you design a very complex probiotic that's not just one or two species that are contained in your yogurt, but are 50 to 100 different species that are really core and foundational. But giving a probiotic is not enough, because if you think about it, if someone has, you know, an altered pH in their gut because they have stress or inflammatory bowel disease or IBS or something that's impacting the microenvironment of their gut, introducing these microbes is like pushing a bunch of civilians into a house fire and telling them to come back out unscathed. You're pushing them into an environment that's not safe or conducive for their growth or survival. And so you really do need to use tools to balance out the microenvironment of the gut and give these microbes a surviving and thriving chance, typically through the use of actually prebiotics. So if you send them in with a food source that they can at least use, it almost acts like a shield, like their arm there, to help them kind of continue to thrive, continue to edge out some of those bad microbes and slowly restabilize the gut. And so it's really interesting, some of these symbiotics, which are then a combination of probiotic and prebiotic, they're becoming more and more popular. But again, trying to understand, you know, which dietary fibers are using, which prebiotic molecules, which microbes, and in what setting, that's where it kind of becomes quite complex. And so that's one of the studies that we have going at the moment. This is the $10 million Western study that I brought with me when we moved earlier this year, is this, this use of the gut microbiome essentially as a biomarker of overall health to define what your nutrition should look like. And so we've paired up with LifeMD, so that's Microbiome out of the University of Calgary. They've got this great app that they developed for IBD and celiac patients that we're kind of stealing a left arm off of this app to create our own version of it. And so essentially what's going to happen is we take a simple stool test that's ordered through the app or by your care provider that gets mailed to Microbiome, which is our partner corporation. It's a $180 test, so it is actually covered by, or presumed in the next 2 years to be covered by healthcare in the Western provinces already. And then there's, I don't like using the term AI tool anymore because ethics gives me a headache over it, so we're just going to call it some bioinformatics at this point, that we use to essentially show your microbes were capable of using these types of dietary starch, these types of dietary fibers, and not those. And so these are the foods that contain the safe fibers, the safe starches. These are the ones that you should be eating more of. These are the ones that your microbes weren't capable of utilizing, and based on your disease state and your overall health right now, these are the foods that we're going to tell you to reduce for the time being. So we rerun the test roughly every 3 to 6 months, and we kind of reprogram then how much has your gut microbiome changed? Can we start to increase the types of foods that are safe for you at this point? And can we kind of push you back into a remission state and help you maintain that through reprofiling your gut microbiome and consistently providing you with personalized nutritional advice? And so, you know, there's a lot of different groups and settings that we're starting to study all of this work in, a lot of different health settings. IBD is always going to be my baby because I have IBD. I was joking with Brennan earlier this week because he was kind enough to last minute pull me in for a scope. So I actually wrote this entire thing while a little bit high on fentanyl, thanks to Brennan. But IBD will always be my baby for that reason. But that said, I mean, the gut plays a role in so many other health settings. And so, you know, this department's pretty widespread, and I think there's a lot of opportunity for us to kind of try to understand what the microbiome means for other organ systems and other disease settings, infancy and gut microbiome development. We have these collaborations with CHILD that we're really trying to understand what all of this means. And then what does that mean then for the child's development, promotion of IBD in early life, what this means for surgical outcomes, post-operative outcomes, and lifelong journey for these patients as they're diagnosed. And then we also actually have a newer study that's in our Alberta and prairie first responders, primarily firefighters at the moment, trying to understand how life stress and work stress and lack of sleep can impact the gut microbiome and overall gut health. So what our preliminary studies actually shown is over 60% of prairie firefighters have a very significant gastrointestinal health score. Probably not quite diagnosable yet, but they're unfortunately being pushed into kind of mental health leave instead because it's what WCB prefers of them. And so they're kind of being missed. And so it's quite interesting how, you know, even the general population is experiencing these types of gut stress issues that are impacting things like mental health and other factors that I'm sure most of the physicians and researchers and other staff in this room have experienced themselves. And so, you know, the take home from all of this is the fact that the microbiome is a very heterogeneous community. The viruses play a role, the bacteriophages within that community play a very heavy role in the gut. The fungi and the bacteria certainly play very important roles, and these roles can define disease. We're really starting to get to a point now where we can almost use AI tools and a simple stool sample to make diagnoses, which is incredible if you consider that's, you know, that could be available in the next 5 to 10 years. That's really quite shocking. And so using these tools to kind of not only define early diagnosis, but help patients to understand what they can do to promote their own remission for those who are already diagnosed, or improve their outcomes, prevent surgery, or prevent post-surgical relapse. All of these factors are really quite fascinating. And the fact that we can use lifestyle changes and nutritional changes, though they are not easy at all times, is quite fascinating. And so the point is that, you know, it's not as simple as one cure fits all. You can't just tell someone to go to Amazon and order an inulin supplement and they're going to be okay because it's a prebiotic and it's healthy for you. That statement's not as simple as everyone seems to think it is. And I think dietitians have recognized that for a long time, and this ability to have to sit down and really talk through which foods are triggering, which foods do we feel safe with. And obviously not just in understanding kind of the gut food relationship there, but also the mental health and fear factor that comes with that, because especially coming out of flare, a lot of these patients are going to be quite afraid of certain foods that they may have thought triggered them in the first place. So it's a quite complex interaction, and we're trying to do our best to undertake uncovering how that works. It's a big team. It's a lot of people who have played a role in all of this, and it certainly comes back to the patients overall as well. So thank you to everyone who has been involved, and looking forward to increasing our collaborations now that we're home. So thanks for having me.
Thank you very much, Heather. That was a tour de force. Do we have any questions from the audience? At the back.
Murphy from the Netherlands. Living for some weeks. Very interesting. Well, thank you very much. One of the issues, of course, in my view, and it's so difficult to study this, is that food items are consisting of components. So if you have a specific diet, and you focus on one component, you try to make an association between certain outcome. Mostly you're not sure that other components could have a role there as well. So how are you able to disentangle those different effects of components?
Yeah, so just for the online audience, the question is essentially, you know, when you do nutritional research, how do you know that it's just the dietary fibers when food is not just dietary fiber? There are a lot of other nutritional components in there. And so how do you kind of control for all of that? It is complicated, and I am almost guaranteeing that there are other nutritional factors that are involved in this mix. But when we take, you know, the culture-based assays, and the only thing that we're adding back in is a single dietary fiber or a single starch, and kind of watching how these changes unfold, I think that's where we're kind of starting to understand this. So the original clinical trial that led into this one was the prior Western Family Foundation study. That clinical trial, the only real change that we were forcing patients to make was the addition of a single type of dietary fiber. And there were different types of dietary fiber depending on the individual, but it was a single type of dietary fiber. And then we kind of, you know, we gave them overall general advice, but the rest of their diets were quite varied depending on the individual. And consistently, the addition of that one dietary fiber based on the precision tool was enough to make the change. Now, I'm not disregarding the fact that there are a lot of other food factors that are involved, and our team's done more recent work that has shown that, you know, even with that fiber, the polyphenols that are bound to it actually seem to be the most beneficial part of that fiber. And we've kind of started to identify which polyphenols, and so how do you understand, you know, a navel orange versus a mandarin is actually quite different. The mandarin is better for you. So how do we start to kind of understand, you know, which food factors and how to balance the rest of the diet? I'm not disregarding how complicated that is for sure, but yeah, we do certainly have a lot of evidence that the addition of these fibers and these specific polyphenols is one of the keys.
Chris.
Chris Power, neurology, great talk. I wondered about the contribution of other microbiomes besides the gut. We hear a lot about there might be a pulmonary microbiome, you mentioned vaginal microbiome, oral microbiomes, obviously. Do you have thoughts about their relative contributions to inflammatory disease?
Yeah, for sure, especially the oral microbiome when we're talking about inflammatory bowel disease and some of the gastrointestinal conditions. But there are links with the oral microbiome and other disease settings too. The oral microbiome is really just kind of the front half of the gut microbiome, to be honest. It's the microbes that produce the enzymes that start the entire digestive process. But they also produce a lot of metabolites that are going to signal all kinds of other, I mean, they're doing the same thing, right? you know, the tongue and the mouth is no different to the colon. You've got a lot of metabolites that are being produced by these microbes and taken up into other organ systems. We have more recently started taking oral swabs in our patients to try to identify kind of that interaction, that relationship. And there are lots of other people who have been doing this too. But yes, I would say of the two microbiomes in the body that I think are the most important overall to almost every organ system, it's probably the oral and the gut microbiome. They are the largest of the microbiomes. But when you start talking about specific organ systems, there are many other organs that contain a microbiome. And I mean, they're kind of this hoopla over a tumor microbiome. Does it exist? Does it not exist? Was it contamination? Was it not? And so, I mean, there's lots of different features of different microbiomes in the body that play a role. But you're right, I think the oral microbiome is kind of the next step. You know, I sit here and say within the gut microbiome, we've done a bad job. We've ignored the virome and the microbiome, but we've also ignored other organ system microbiomes like the mouth as well. So it's something that we're trying to work on, but you know, convincing funders that you need double the amount of money to study both is not always easy.
Right.
Had a fantastic talk. Really glad you moved here.
Thank you. Me too.
A lot of my IBD patients ask me about fecal transplants, and I tell them there's a signal in UC, not so much in rooms. What lessons do you draw from all of those trials that have been done, generally not very successful? Which you tell my patients?
Yeah, I think FMT, like the way I've typically described it, FMT works really well for something like C. diff, where it's an infection, it's temporary. Once it's cleared, your microbiome is going to reestablish itself and boom, we're back to normal. That's typically a healthy individual or someone who's dealing with a storm of one microbe pop up, and it will disappear on its own, but the FMT helps it disappear faster. When you're dealing with IBD, you know, I think we're starting to understand the role of the appendix and reestablishing the microbiome of the gut into a not so healthy way. It almost acts as a storehouse of either healthy or very unhealthy microbes. FMT, you're not going to shoot it all the way up into the appendix, so I'm not really sure how you'd fix that. But you're battling so many different things. And I think personally, you know, if you look at studies of FMT and IBD, one of the ones that's the most outstanding was a combination of FMT and pectin, which is one of the types of dietary fibers. And they showed that the FMT was more sustainable, it was more clinically impactful. And so I think it again comes back to what I had mentioned, that it's not necessarily that FMT is a complete flop. I think it's helped to guide more complex probiotics and better knowledge of which community of microbes needs to be delivered as a probiotic. But I do think that a probiotic alone or an FMT alone isn't going to be enough, because you haven't done anything to correct the microenvironment before you deliver it. And so I think that is probably one of the reasons why you have to give FMT over and over and over and over again for a very long period of time before you see any impact, is likely because you have to wait and watch and continue delivering it to try to nudge out all those bad microbes and reestablish the health of the microenvironment of the gut as well. But I don't think that it can be done with microbes alone. I do think that we really need to use nutritional factors and different drugs that can help reestablish the gut environment too, because it's the host cells that are producing a lot of those different metabolites that derail the microenvironment too. So it's not just the microbes themselves doing that. And it might have something to do with the oral microbiome as well, who knows?
Okay.
Yeah, I have a question kind of about the hospitalized patients in general, obviously for one for the stuff, but dietary practices in hospitals can be quite different. And you know, a lot of our movement is actually Ensure, and supplement drinks is a large part of their diet. I know now if they have a prebiotic, I think Ensure, and they have a normal one, and it could be usually normal and high or whatever. And I'm just wondering from your perspective, looking at kind of this drink where it's got a bunch of minerals and vitamins, but also like a large part of that substrate is sugar.
Yeah.
And then this one that has a prebiotic added to it, and thinking of kind of the do no harm perspective of this, which one for average hospitalized numerous chronic disease patients in the context of possibly worsening inflammation from these prebiotics, do you think would be less harmful?
So the questions, you know, if you take a patient who's hospitalized, you're talking about Ensure, which has typically been rather devoid of fibers. And now you take these new versions of it that have kind of the prebiotic supplement at the back end. Is there kind of one that's perhaps better than the other considering the microbiome? I think a big part of this is, the first question is how long are they going to be on it? What's really interesting is there's kind of two versions of studies that have come off of this. One is showing that Ensure or enteral nutrition in patients, even though it's devoid of fiber, actually completely changes the penetrance of the microbes in the gut. And people think that that's where some of the benefit is coming from. So it's kind of a temporary starvation of the microbes in the gut to prevent the microbes from penetrating, allow the gut to reheal, the barrier to reheal, the mucosal membrane to return. And then at that point, can you start to slowly reintroduce prebiotics and allow for kind of the growth of the microbiome to return? That's kind of one path of thinking. The other, and there's a CERC-funded study with Janelle Lunkin and Kevin Jacobson at UBC right now, where they're looking at, can you take Ensure and pair it up with different types of prebiotic fibers? And are there some that are more beneficial than others? So exactly your question, you know, which ones are actually safe in this setting? And so they've kind of started to find off the backs of some of our studies very similar impacts, that there are certain types of fibers like the pectins, kind of the same idea as delivering them with an FMT, that are very beneficial when you combine them with something like Ensure. That study's ongoing though, and there really haven't been very many studies that have looked at either reintroduction of a fiber diet after something like Ensure or addition of certain prebiotics at the same time. But so far what they've been finding is the addition of things like pectin or very low amounts of inulin can actually help to promote gut health and healing and reestablish overall health if you combine it with Ensure. So there's a chance that those prebiotic supplemented Ensure are possibly healthier, but I don't think that we have enough data to actually be able to say that yet. But that is one of the reasons why Ensure is thought to work, is that it's kind of preventing this penetrance of microbes into the gut, which is quite interesting in itself. So there's some online yet. So Finlay McAllister has asked, how long will broad spectrum antibiotics disrupt the gut microbiota before it returns to baseline, assuming the patient doesn't develop C. diff? Has done work showing that antibiotic exposure worsens COVID and viral URTI outcomes, dose temporal response, and it's still present even out to 12 months after antibiotic exposure. But the gut microbiota is thought to go back to normal. So, I mean, the studies of this kind of almost two-part question. The studies of antibiotics and the gut microbiome actually show that the gut microbiome bounces back after you stop antibiotics, depending how long you were taking them, in roughly 2 weeks, which is pretty incredible. I think it speaks to kind of what that baseline microbiome is for a human being after about the age of 4 years old. And so from the other half of that, looking at what this means for viruses, I think one of the flaws, and this is why Andy works here, is because we don't understand enough about viruses and how the viruses play a role in all of this. So when we talk about the gut microbiome bouncing back, we mean the bacterial species look pretty normal after about 2 weeks. We don't do enough to understand anything about the fungal species or the bacteria that are within them or the bacteriophages. So I'm not sure. I haven't seen any particular evidence about sustained viral infections after antibiotics, but I'm sure it's something that's possible. Leo is asking, since presence of intestinal inflammation is a trigger for bad outcome in patients exposed to prebiotics, can foresee simple fecal calprotectin help to advise the use of prebiotics or not? I'm not sure that FCAL is enough. I think it's certainly a part of the equation. So it's kind of like I was saying, you know, you kind of have to have this perfect storm of changes in the microbiome that occur, that you're not fermenting a type of dietary fiber. You may have a very high fecal calprotectin and all these signatures of having, you know, worsened IBD, but if your microbiome is capable of utilizing some of these prebiotics, like inulin, for example, the studies show that it's actually extremely beneficial, Leo's study included, if you can utilize the dietary fiber. But if you can't, now it's a two-step approach. You know, you couldn't use the dietary fiber, so we know that it's going to be in the gut in a whole form, an unfermented form, but now how is your gut going to respond? So do you have kind of more active disease, more immune cells present in the gut, they're primed and ready to have an inflammatory response? that's going to put you at a higher risk of having this inflammatory signal in response to your diet. So I think it's complicated, and I think it involves both the host and the microbiome communities in the gut, and that's a part of what our testing is trying to do at the moment for the precision nutrition trial. That's it for our online questions there. Does anybody else have a question? Or?
Yes, please.
Given the involvement of the microbiome in the pathway, do you see a future where we go back to targeting new antibiotics to target the fat? I know that was kind of in vogue in the past. I use antibiotics in IV.
Yeah, I think it's tough. I think it really screams the two issues that we have with society. And the number one is the fact that people want a quick and easy solution, right? And so I don't think that you can just target one particular microbe unless it is an infection state and have everything balance out. And that's because the microbe community outside of infectious pathogenic microbes, you actually have a lot of microbes that are pathobionts. And so they're naturally kind of fine to be present in the microbiome as long as there's not too many and as long as they're not being naughty. But when you change the microenvironment of the gut, I think you can end up with a situation where they are primed and more capable of outgrowing the beneficial microbes, and now they are considered almost pathogenic. And so now we're having a problem. So you don't necessarily want to eradicate any particular microbe, you just want to calm them down, which can be controlled through, you know, promoting the growth of the beneficial microbes, particularly those that are capable of this fermentation process, recorrecting the microenvironment of the gut. Bacteriophages really play a massive role in controlling the microbiome community. And so kind of, I think it's more a question of what approaches do we need to take to kind of promote that balance, that stabilization? I mean, you think about them like they're almost a human community, you know, how do you calm everybody down and make them stop hating each other? That's the question, is how do you know, just calm stuff down and not have one or two loud kids in the room. And so I don't think antibiotics will be the simple solution because there's probably a lot of different microbes that you'd have to individually target and not wipe them out, but calm them down. I think it would be quite complicated.
Please join me in thanking him.